It is 12 o'clock Eastern. I know for Justine in that central time zone, it is 11. It's easy math. I want to welcome everyone to today's Vet Girl YouTube live session. Super excited to have Dr. Canfield here. We're going to be talking all things ears and otitis externa today. Super excited, super important. And I know Justine and I always joke, one of the things we say to ourselves, we would always, if we went back to veterinary school again, what we would pay attention to is dermatology. Even in the ER where Justine and I live our lives, it's like every other patient that comes in has otitis, has pruritus, and they're coming through the ER. So it's not just limited to Dr. Canfield and his derm practice. I wish I learned a little bit more. That's why we're here today. And a lot of you do know that whenever we first log in, we love to know where you are logging in from around the country and around the world. So please go ahead and type that into the question screener. I'm going to start looking. You are doing it already. You guys know you're pros. We have Kathleen from San Francisco. We have Karen from Kansas. John from North Carolina, Tiffany from Georgia. Keep typing those in. Give quick introductions as you guys are doing that. I'm Garrett Paxinger, the co-founder of Vet Girl. I'm a critical care specialist, and I'm logging in from fairly sunny but a little chilly Philadelphia, Pennsylvania area, just suburbs outside of Philly. What about you, Justine?
I'm logging in from St. Paul, Minnesota, where it is a brisk, beautiful 60 degrees out.
And Dr. Canfield's
like, no way.
We were joking about the coldness of kind of where we live. Dr. Canfield, what about you? Where are you logging in from today?
Newport Richey, Florida. It's only we're 75, 70. It's cool. Last week it was 90.
Justine and I just happened, we were co-lecturing and we were in Florida the other weekend. It definitely makes, as you can see us both wearing our Vet Girl hoodie sweatshirts, we came back to our respective locations in Justine, Minnesota, me in the Philly area. And it's like, this feels even colder now than it did before after being in Florida. So Dr. Canfield, I'm both mad at you and jealous at the same time for your beautiful weather.
Oh, I'll keep it for now. You guys, I'll just commend you on your ability to withstand the freezing temperatures.
I love it. Yeah, we are all over the place here. Colorado, Portugal, San Juan, Puerto Rico, Sacramento, Washington. So keep typing in where you're from. We absolutely love reading where our users, where our members, our friends are logging in from around the world. Let's get to our intro as you guys are doing that. We want to get you that hard-hitting information as soon as possible. As I said before, super excited to have Dr. Canfield here with us today. We're going to be talking about otitis externa and practice essentials. So we are all ears, pun intended, to get that done. Many of you do know that whenever we have the fortune, the pleasure of an educational partner like Merck Animal Health, we're able to provide this race-approved CE event absolutely complimentary to the veterinary world. So thank you to Merck Animal Health for being a great educational partner and being here with us today. I also wanted, I'm going to leave this slide up for now for a second as I talk, and we'll have it one more time at the end of the presentation. But as we are getting closer to Halloween and those scary costumes, this is the perfect time to talk about the Merck Animal Health Scary Ear Sweepstakes. So as you see on the slide, and again, I'll leave this up now and bring it up again later, veterinarians, veterinary technicians, send them your cringe-worthy ear photos. It's super easy to do. Justine and I joke that QR codes like 5 years ago were everything. And then they went out. Like nobody wanted a QR code anymore. And then COVID hit. You can't order a beer or your meal at a restaurant without your smartphone and a QR code to see those menus. They're not giving out paper menus. So we all love QR codes. You can either use that URL, tinyurl.com/scary-OE, and Justine just put it in the chat as well. Thanks, Justine. Or use that QR code. And so please go ahead and send them your super scary photos for the chance to win some awesome stuff, an amino dog behavior and activity monitor. So take a look, check it out, send them your super scary ear photos. Let's get into just a little tiny bit of Vet Girl housekeeping. If this is your first Vet Girl event, we're the tech-savvy way to get your online education in a multimedia approach. We have YouTube live events like this. We have full webinars. We have podcasts, blogs, videos, a forum, a discussion board, so much more. So however you like learning, whether it's reading, listening, watching, we have that opportunity for you. So make sure you check that out. We also have not only individual sessions like today, we have certificate programs, value add part of your membership. Currently, we have 6 different certificates, as you see on the screen here: basic and advanced emergency medicine, practice management, nutrition, anesthesia and analgesia, and ophthalmology. Part of your membership as we speak today, so make sure you take advantage of that, as well as I was saying about our Vet Girl Forum. Whether you have a case you want to consult on, a vent over a venti, look for a job, post a job as a member, that's accessible to you as well. So in talking about QR codes, and Justine already put it in the chat, one of the URLs, but this is how to get your CE certificate for today's event. As I was saying, everyone loves, it's a love affair for QR codes again. So in order to get your CE certificate, use your phone, use that QR code or the link here or the link in Justine's chat. I'm going to keep this open until 1 o'clock Eastern today, so approximately 30 minutes after the session is over for you to get your CE credit. If you're not super familiar with QR codes, all you need is your fancy iPhone or Android, whatever it is. Just open up the camera feature, and what you're going to see on that camera feature is some type of link. It'll recognize. You see those yellow brackets around the QR code? A little button will come up. Click on that. It's going to bring you to a form to fill out. Again, just like the scary ear sweepstakes, I'll put this up now. Justine put the code in the question screener area, and we have a code here as well. So please make sure by 1 o'clock Eastern today, you fill out your form so we can send you your race-approved CE certificate. Final quick note, YouTube, I know they come in like the little small screens depending on what device you're looking at. Please know that bottom right icon on your YouTube page, that'll put full screen so you can get in bigger. You don't have to watch it in that micro window. That's a YouTube related thing. Don't yell at Vet Girl for that. YouTube. Make sure it's big and full screen for you. All right, I'm done talking. Super excited again to have Dr. Canfield here today. Dr. Canfield, Justine and I are going to pop ourselves out in just a second and leave the floor to you. But if you can give our audience a little bit of a background of who you are, where you trained, what your practicing and loves are right now, and then please take it away. The floor will be yours. Thanks again.
Thank you. So while they're popping out like popcorn, for me, I graduated from Mississippi State, went into private practice immediately upon graduation, bought a practice. Then within a few years, decided I wanted to kind of pursue the dermatology side of things. Trained out with Animal Dermatology Clinic in Irvine, Tustin area of California. Cycled through Marietta, Georgia, California, and Florida throughout that time period. I still do general practice, so I actually currently still work in the original practice that I purchased when I graduated college. We do derm and general practice through there. Currently have a couple of residents from Kansas State University, actually. Do some flea research, and I love to do a lot of the stuff with ears and parasites and allergies, all the normal stuff here in the world of Florida and fun here. Today I want to go through kind of a brief thing with regards to ears. Obviously, in a lunch session, we're not going to get through everything, but we're going to get through some primary things and maybe some stuff that tends to cause us pain that we don't really recognize. The topic's super complex. In all honesty, I spend a lot of time now doing human otology lectures, and we just got back from the otolaryngology meeting in LA. I will say that at best, veterinary otology is in its infancy. So some of the stuff that we talk about today might not be what I talk about tomorrow. Restraint, super important. A lot of people fail at otoscopic exams and they're awake patients purely because they don't know how to train the team, how to manage the patient. Equipment's a huge issue as well. If we can't see what we're looking at, it's really hard to assess. Basic diagnostics, obviously, we're going to hit the importance of cytology. Cleaning the ear. That's one of our number one failures is we start medicating an ear that we never bothered to clean, and it makes a tremendous amount of difference. Today, we're going to briefly, super brief, hit some of the FDA approved medications from the various companies. Obviously, there's some generics and there's tons of them. I didn't include all that because we just don't have the time. And then we'll hit a couple of things on complications, and then we'll kind of move from there. My basic dermatology toolkit, whether it be for ears or skin, you got to have a microscope with an oil objective. I've gone to do little in-house seminars, and I get there and they don't have a 40 or an oil that works. They got a 4 and a 10 that they use for fecal exams, but no higher power magnification for their scope, which makes it essentially impossible to get you back to the nose test. I'll use a pharmacy spatula, hemostats, different things, but mainly for the ears, cotton tipped applicator, frosted slides, and a pencil, right? And we're going to heat fix them and stain them and kind of go from there. As far as, in my opinion, some of our chief exam problems, getting the patient to hold still, having the patient not resent an ear evaluation. These are the things I get from practitioners sometimes, including residents. I don't know what I'm looking at, so I look. Or I didn't learn that in vet school, so I don't really need to know it. God knows that's not the case, right? I only use a sniff test. We still see that a lot. People are like, oh, I can smell it. That's Pseudomonas. Or I can smell this yeast. You know, some guys are really good at it. I've done a little blinded group and they're close. But the fact is, we still need to be looking. There's people that just don't like looking. For those people, I usually say if one of your top 3 metrics of things that are being seen in your practice is ears, it's probably a wise practice builder to learn to like ears. The people that say I treat them all the same, so why look? We have some variety of medications now where I'm not so sure that we're going to be treating them all the same. As far as restraint goes, that whoop, there I went. Yeah, as far as restraint goes, normally I'm going to have the technician over the top of the muzzle, and she's not gripping hard, right? She's holding the muzzle to her upper part of her chest, and then her opposite hand is pulling the shoulder of the patient up against her chest. That way, if that patient moves, she can lean back. She's not having to hold it out away from her and manage it that way. She's got it up close to her body. And then as we move to the other view, what she's going to do then is we're going to turn the patient and the same setup, right? That allows me to grip the pinna. She doesn't have her hand up by the head to where I have to worry about if they have their hand up close to the ear canal or the mandible, they can actually partially occlude the canal, which then results in the otoscope hurting the patient as you enter the canal. You know, this is the kind of classic view from our traditional handheld operating otoscope image. I can see some things because I see it enough that I know some things that are there. I can see the malleus, I can see the pars tensa. Can't really identify much of the pars flaccida. It's not the perfect view, but if I see that, I at least am aware that I have now seen the tympanum. If we look at the diagnostic head, that's the big one that's handheld that you can swing the round lens away from the otoscope. Just know that if you see a black bezel or black frame on that, it's meant for the short otoscope cones that are used in humans. It will not give you a focused image like you see here. That's blurry. But if you hand that scope to the average person, they'll say, "Oh, I see the eardrum. It looks great." Well, they're not even seeing it. So just stuff to think about. Here's an image. Obviously, this is more with a videotoscope or a rigid scope where I'm getting a lot more light flooding the space. The swollen part, so to speak, at the top is just an air-filled pars flaccida, and beneath that you can see the pars tensa. A lot of people will see this and think, "Oh, there's a mass," but this is just some of the normal and anatomic variation, especially with sedation. As far as our world of otoscopes, right? We all started with things like this. Uh, this is the regular diagnostic head. The next one here is the operating head otoscope, followed by the macro view scope that Welch Allen came out with. Before we go to the next one, I want to say, if you notice, I'm in a down position because most of these patients were sedated because I was going to work in the ear canal. But recognize that many of us need to start thinking about we're going to have a long career. If we're doing a lot of things in a head and neck down position versus a heads up position, we're setting ourselves up for head and neck disorders that may affect us for our lifetime. And it's important as we move forward that we actually look into what our options are. So these are many of the handheld options that I have that I honestly never use at this point. I probably, other than to demonstrate how to use them, I probably haven't picked one up in a while. This is some of the assortment of rigid scopes I tend to use. The one in the middle where it's just a straight scope with no other stuff, that's what I use for most of my otoscopic exams and a lot of my basic ear work. And then if I'm in a good place in my life, I'm going to get to a heads up position like this, to where now I can actually be in a vertical position, be erect, and be using that equipment without the worry of causing impingement upon my neck. By the way, I've been doing it long enough. I already have some neck issues. As we move to the next one,
Mike, if you can hear us, we lost your sound. So if you could potentially refresh, there's no audio. So if you could refresh, that'd be great. Thanks. Can you guys hear me, Justine? If you could type in the comments and let us know, that'd be great.
okay.
All right, we have you back. Thanks, Mike.
Sorry, guys. Where were we?
We were just at the point where you're talking about neck pain.
Okay. If we can maybe back up just there you go. That's good. Uh, were we still around for this one, or I was already out?
Nope, this is perfect. You had just clicked on this slide with a massive amount of cameras and screens.
Okay, perfect. So sorry about that, everybody. Ultimately, there's a bunch of equipment options, variable pricing range and stuff. There's lots of different companies that are available. I just encourage you, invest in your health. We talk about mental health and all that other stuff, but how many of us, other than the surgeons, actually talk about heads up display, getting the pressure off your head and neck? The ENT surgeons, that's one of their top things that takes them out of their career early is neck and chronic pain. So, guys, we go through a lot of stuff anyway. So it's important that we try to take care of ourselves. Uh, here I am. Obviously, it'd be better if my head was facing forward, but when I'm trying to show you guys what we're doing, I just have them put the screen beside me. So I've got the patient, I've got the camera and scope in a hand, I've got the instrument in the other hand, and I'm doing this by myself. A lot of people will have somebody help them by holding the pinna and stuff like that, but I've got these big bare hands, so I can usually do most things. But ultimately, I've got everything from a tube flush to a ear loop going in to get debris out. And then on the next image, this basic anatomy. Some of the patients, if their auditory tube or their eustachian tube is patulous or open, sometimes you'll see the eardrum moving in and out as they respire. or you'll see in a sedated patient a distended pars flaccida, which is what's in this photo. And that's okay. It's not hurting anything. It just means their auditory tube is dilated and they've just filled their middle ear cavity with air. It can be full of fluid, but we'll go to the next image. And then CT wise, where those blue or aqua colored arrows are, that little white rim, that's actually the pars flaccida that's pointing to. So that same air-filled structure that we saw before is what is being demonstrated with those arrows. So you can see it on advanced imaging as well. The next one here, I think the tympanic membrane in general is super pretty to me if you get a nice one. So with this one, the pars tensa, which is the part of the eardrum that most people recognize, the pars tensa is where the arrow is. Off to the left is the pars flaccida, and then the white bone structure there is one of your ossicular chain members, the malleus, right? So if we go to the next image, you can see the malleus, and this is of a cat. But when we're looking in that ear canal, we need to have equipment that allows us to visualize this. So for somebody to say, hey, this is a completely normal eardrum, it's difficult without appropriate lighting, for one. So we all end up with an old battery that's damn near dead, and we're trying to figure out, oh yeah, that looks great. And they're looking at the side of the ear canal wall versus the actual, eardrum. If for me, that's important, right? We have to be able to see and get a good visual. As we move into the drugs that are approved and available for use, I tried to cover a pretty good assortment, and I think we'll be able to get through them. Cytology is a steroid combined with DMSO. And guys, I know you're all over the world, but I only did the U.S. Products, and I know some of them exist and some of them don't, and some of them are in different namesakes in different parts of the world. But I like this one if I have a dog that otherwise does not strike me as the allergic patient, or it's a mostly controlled patient, say on Apoquel, and I can top it off with a little Cytology and just keep their ears quiet. Might be something I'm using a couple, 3 times a week, sometimes just periodically. You get that owner that says, the ear still smells and looks and otherwise seems happy, but the dog's bothering at it a little bit. Cytology might be my go-to because it doesn't have antibiotic, doesn't have antifungal, and that gives me an opportunity as an anti-inflammatory. For the next group of drugs, right, these are all going to be in veterinary medicine, with few exceptions. Most of these drugs are going to be combination products. What I try to do is teach the residents and other veterinarians learn what the ingredients are. There's going to be several in the next series that are gentamicin, but you're going to see the steroid change. A lot of them will use clotrimazole and stuff. If you read the labels, they will say, for example, Mometamax, they say Malassezia, Pseudomonas, coagulase positive staph, Enterococcus, Proteus, beta hemolytic strep, and it's a once a day product. Most of this, if we look at mometasone, it's a little bit softer steroid than, say, betamethasone, but I like most all of these drugs that we're going to cover. I'm going to kind of preface this to say that there are some things that I do that are extra label with this, and not necessarily in a bad sense. If you look at how they're labeled, it's X number of drops per patient size. We all know that some of our clients can't count. The other thing they look at sometimes is this stuff was expensive or whatever. I usually dose these via syringe. So if it's a small dog, Shih Tzu, Lhasa, Boston, whatever, maybe half a mil for each dose. If it's a big dog, say German Shepherd, Malinois, some of that stuff, I'm going to hit closer to a mil of volume for each dose. If it's a Great Dane, if the whole ear canal is affected, I might step that up toward 1.5 mils. And you're going to tell me that, well, that's going to blow through the volume. Yes, but how many failures do we get that may actually not relate to a product failure, but a failure to comply? So as we move to the next slide, we're going to have Otimax, which if we compare with Mometamax, what's the difference here? it's the steroid, and then it's the application frequency. So with the betamethasone, it's a little bit heavier duty steroid in my mind, as far as it's not quite as soft as the mometasone, but similar label application, and then up to a twice a day. I don't use as much of Otamax at this point, mainly because it doesn't mean I couldn't use this as a once a day drug, but if I'm minimizing my stuff on the shelf in my hospital right now, probably Mometamax, but I've certainly used plenty of Otamax in the past. I think that as we move through some of these drugs, we always look for things that will improve compliance or dosing. This is Verbac's Exotic product, which again, if we look at the antimicrobial, is gentamicin. Another classified as sort of a soft steroid is hydrocortisone acetonate, and then miconazole nitrate. I like, to some degree, I like this application because it instills a mill. Some of the dilemmas for me is it's a 10 mil dosing. So if I have a dog where it's a chronic or a longer standing ear infection, I know I'm going to potentially be treating them longer than maybe what the label would say, because I'm going to judge when I stop treating based on that ear canal being back to normal, and hopefully have some self-cleaning, get started again. So it is a once a day, 10 mil volume. Usually I'm going to dispense more than one of these, and then each actuation of that pump will instill a mil. The other thing is, I don't always like, if I've got both ears being treated, I'm a little funny about this tip going into each ear. So I have the owner kind of hover a little bit over the hole versus burying that tip down into the ear. But that's kind of my preference. With Positex, now we're looking at an antibiotic and antifungal change. And so if we look at orbifloxacin, so now we're in a fluoroquinolone type antibiotic, and mometasone furoate, which is like we had in Mometamax, so a little bit softer. The posaconazole in here, if you haven't played with this antifungal, I'd be tickled to death if I had a mometasone and posaconazole just by itself, because I think it'd be great for some of these allergic yeasty ear dogs, and then I wouldn't be exposing them to antibiotics at the same time. But either way, this one's approved for malassezia, staph, Pseudomonas, enterococcus, and it is a once daily application. And again, I do dose volume based on size of the ear canal. It does pretty good. If we look at Batralotic, it's enrofloxacin and silver sulfadiazine. That emulsion, I will use this if I've done laser surgery in the ear, because I like the silver sulfadiazine as a kind of burn cream. Obviously, it has been around a little bit longer. The treatment modalities that it lists there, as far as malassezia, staph, Pseudomonas, Enterobacter, Proteus, strep, Aeromonas, Aspergillus, and then Klebsiella and Candida. It is listed as a twice a day medication. I can confess that more often than not, I will be using this as a once a day, because compliance, I think, declines. So I'll tell them how much volume I want and that I want it once a day. The biggest thing here is Trazodone right now. If you notice, almost nothing have I put dog and cat. So almost everything we've covered thus far, if we use it in a cat, we're in the extra label sense. Trazodone is at least labeled for dogs and cats. The antibiotic is neomycin. The anti-parasiticide, antifungal, so to speak, is the thiabendazole, and the steroid is dexamethasone. I will put a note of caution here. With some frequency, I have seen lots of cats where they've had kind of chronic use of Trazodone. Just remember that any of the steroids topically applied can cause dermal atrophy, follicular atrophy. So you'll see these cats or dogs where Trazodone has either been locally applied or chronically used in the ears, and the skin will get thin, the hair will be gone, and it'll almost look almost look like scar, or you can almost see through and see the muscle, depending on what the location is. So with this one, it is at least labeled for dogs and cats at twice daily, and refrigerated. Been having some back order issues, but at least we have it as an option, and it's watery, so that's nice in some situations. Some of the more recent things with the residual activity products that, we're treating them once and kind of forgetting about them for a while. So the Claro and Ocernia of it all. Claro is a fluorophenocal, terbinafine, mometazone. So you see, we tend to like that mometazone in the ears. Treatments approved for malassezia staph. I want you to think about this. If we don't do cytology and there's a mixture of a fair number of rods, this may not be the right choice, right? Because staph should be round. Even though you don't know for certain what that round organism is, if you do cytology, if you see malassezia and round bacteria, you got a decent chance for this to work. Where you're more likely to have this fail you is you have an ear that's full of rods and you pump it full of Claro or Ocernia. And we see this a lot, is why I kind of bring this up. The duration of effect is supposed to be at 30 days. In the ideal world, it'd be nice to have the ear cleaned prior to treatment. As we move to the next one, Ocernia is a more viscous base, so it still is fluorophenocal as the antimicrobial. Terbinafine is the same antifungal as Claro. The steroid change, so betamethasone, acetate. So again, malassezia, staph. If you take it out of the refrigerator, you need to use it within a 3-month. Usually, I set this up in my practice where I will apply to a clean as I can get ear, then I will reapply in a week, and then I have their recheck established at 45 days from the original application time, and that's kind of my go-to there. Both the Claro and Ocernia had FDA kind of update warnings that were sent out to all of us that said, for cats, just don't use it. For eyes of our staff and eyes of ourselves and eyes of our clients, probably not best to get the ear medication in the eye. I think about that a little bit, like probably not good to pour hot coffee in your lap, but that's the way of the world. Suralan, a lot of people haven't had any exposure with this, and I think it's just as Elanco's changed who they are at times. Miconazole, polymyxin B, prednisolone acetate, again, malassezia staph. One thing I'll mention here, many of our Pseudomonas type ears, even though it's not labeled here, you'll notice some of these guys on our sensitivities now are showing that it's sensitive to polymyxin B, but a lot of people don't realize we have a FDA approved product that has polymyxin in it. So that's where I'll at least point you to Suralan. But it's important that ear is clean. If we set it in a cesspool, it's going to be inactivated, as many of these will be. As we kind of move through, I'm a little reserved in talking about some of the cleansers and cleaners. I look at it a little bit different. If we talk about what's typically going to be the safest, well, that's warm saline. I keep in the general practice, because I go through a lot of IV fluids. If I use that fluid bag today for IV use and I've discontinued the fluids, I'll save that. I'll warm that, and I'll use that as my ear flush solution today and then toss it tomorrow. I do use some Burroughs solution with hydrocortisone as kind of my dog goes swimming all the time. Or if I've got the ceruminous ear, the classic would be like the Labrador or the Golden Retriever, then I will take micellar solution as one of my go-to to soften that ceruminous debris. pH Notics or Ceramine are certainly options that fall in that line for me as well. Antibiotic Advanced has some nice compounds that are meant to help decrease bacteria's ability to stick to the ear canal and decrease the formation of biofilm. So it has a nice place there. I do see a lot of people using Triz EDTA, and I do think it has a place. I do not feel that it is a good cleaner. I think it's a good pre-treatment. So if I don't have a clean ear and I've got a waxy ear, excuse me, guys. If I don't have a clean ear and I'm putting Triz EDTA in there, expecting it to clean the ear, I'm probably going to fail. I do think it's a good pre-treatment for some of these resistant pseudomonases and other things, and maybe Triz Ultra with keto is kind of a maintenance, low-level, clean ear, keep the yeast down. And there's just tons more. We could spend a week on just ear cleaners and cleansers. The fact is, we need to start with a clean ear, and that's probably the most important. That I want you to realize that all of the stuff that I've talked about and all of the stuff that I haven't talked about as far as ear medications, ear cleansers, crap that people do for their pets that we don't even know about. I had a client the other day that I was trying to figure out what the devil was in this dog's ear, and I finally got her to confess she filled it full of Bengay. And I'm like, man, I wonder what that hot ear feels like after you fill it full of Bengay. But remember that even the best drugs, you can have an adverse event because that patient chooses that their immune system or their body doesn't like it. So if you get a client that calls you and says, hey, doc, that ear was doing good, we were doing better, and now all of a sudden it's suddenly getting worse, whether that be raised red bumps of papules or like this ear where it's just really erythematous and exudative, but it was getting better, and now it suddenly got worse. Even if you can't see them today, that's the one you stop your medication and say, hold that off until you get in here, and we try to get them in. And that's always going to be a huge thing because you don't ever want to do things that just suddenly make it worse, right? This is an interesting predicament. This patient was referred to me. There's a lot of non-FDA approved packing type materials that are usually based in a anhydrous lanolin. There's some other things as well. But this dog had a half dozen ear packings done. And at the lower end of this slide here, you can kind of see this little bulb, and then it's surrounded by this brown waxy goo. There's a mass sitting right there, and it's occluding the canal. So if we go to the next slide, what we'll see is that's how much goo was packed around and beneath that mass. And ultimately, we removed the mass and then cleaned all the smuts out of the ear canal, and we don't need to treat that dog's ear anymore. And I think that's important is when we talked about learning the anatomy and what's normal, we have to do, a process of, okay, what's it look like? What should it look like? What does normal look like? And then as we move to the next slide, this, when you pull the ear pinna, there's a ridge in the dorsal ear canal that kind of pulls out of your way. If you pull that ear canal, it's the dorsal ridge. That's what you normally hit with the otoscope, and it hurts the patient. So if we pull and retract the pinna laterally as we enter with our scopes, it'll pull that dorsal ridge down and out of the way. If you've ever been crazy like me, this is a cadaver or soon to be cadaver. But if you see the white thing pointing down from the bottom, you see some muscle fibers on it. That's what lives beneath that little ridge that you're retracting. So when we're hitting that with otoscope, we're hitting that piece of cartilaginous material and that muscle, and it hurts like the dickens. That's why a lot of patients, assuming even a normal ear, if you hit that dorsal ridge, that's a habit to learn. That I need to pull the ear pinna more laterally relative to the head so that it flattens that ridge out. And this is another patient just had a mass in the bottom of the ear canal. This is ceruminous gland carcinoma. This kitty cat had some lovely polyps. Remember, we get lots of referrals sometimes for a middle ear polyp, but sometimes the nasopharyngeal polyps are actually quite small. This image on the right side of this slide is actually a scope that we can use to look back over the palate, and that's coming out of the auditory tube, but it's emanating from the middle ear space, going through the auditory tube and now above the pharynx. When you get the big ones, right, it's easy to find them. When they're small, you have to be able to look above there, and many of us don't have a flexible scope to look above there. You can use a dental mirror and things like that. It's just not super easy. The other image was just the polyp in that middle ear space. This is actually an image I put up trying to get people to orient. Is this normal or is it abnormal? You can see the malleus, the bony structure of the ossicle chain there on the right, and then you can kind of see this V-shaped notch to the left of that. That's actually a huge defect in the eardrum. And then the white line is the other edge of the eardrum. I would venture to tell you that I handed this ear canal to 3 different doctors with handheld otoscopes, and they all called them normal tympani. So I do think your equipment's important. This looks like a diseased eardrum, in my opinion, to most people. We have to realize that sometimes with trauma, chronic infection, the classic would be hit by a car, usually on the side of the head. It tears part of the cartilage away from itself or the ear canal, and then it scars shut. And they call that a pseudotympanic membrane. And essentially, the canal no longer lines up and it scars shut. Usually, you have to determine the length of the good canal and see if the bad canal is shorter. And in these cases, it's seldom possible to recannulate this. On the next slide, similar type thing, right? Another pseudotympanic membrane with a CT image off to the side. And what's happened is the canal scarred shut. So the deeper portion of the canal continued to make its normal cerumen and everything else. And now it's caused the tympanic membrane to actually retract into the middle ear space. So the eardrum's still intact, but it's just getting pressed back gradually into the middle ear space on that cat. So this is not just an ear infection when you see these things, right? I think we have some time, hopefully, for some good questions. And I'm sorry if it felt like a razor's knife running, but I think that I'm going to wrap up here and open up for some questions. And hopefully we at least got a quick lunch run.
That was fantastic. Thank you so much, Dr. Canfield. Fantastic pictures and images. We're getting some great comments. For everyone who's attending, please make sure to fill out that survey. I put it in the comments. That will be open for about 20 more minutes. So you can see that here. Either just take a picture of it to access the QR code, or just go into the chat function and you can fill out that Google Forms to get your CE certificate. And we promise we will email that in a couple of days. So stay tuned. Please also give a huge shout out to Merck Animal Health and send your most disgusting, purulent picture of your scary ear to the website here. So you can just type in the tinyurl.com/scaryoe and you get an awesome chance to win. Now, let's take some time to answer some questions. I see some fantastic questions here. First of all, can over-the-counter clotrimazole be used in dog and cat ears?
I've seen clients do it. Thus far, I haven't seen a major issue as far as adverse events. The concerns I usually have would be, did we ever find out what was in there? So if it wasn't a malassezia-based disorder in there, I don't know that clotrimazole would necessarily hurt if it was Pseudomonas, but I don't know that it would really help. I have seen people do it. If you give clients the will and the way, they'll put almost anything in an ear. They won't do it to an eye, but they will put anything in that ear or up their rear or all kind of things. But at least I don't use it routinely. I've certainly seen clients that have used it and I've had to clean up after it and didn't see any major nightmares. But right, that's one of those things where I don't know that I want to have to talk to the liability insurance trust people about if I told them to do it. If they do it, we can work around some things.
Great question. All right. I guess if you see Ben Gay, I always tell people leave
Oh my
orifices and
god.
holes of your pets alone. Let veterinary professionals do that.
Oh my god. The
Uh,
Bengay was fun to get out of the ear. It
I
took me a
can't
little while
believe
to
that.
figure out what it was.
I can't believe that. Also, for those people who are listening, please make sure to type in any feedback and shout outs to both Dr. Canfield and to Merck Animal Health. We'll make sure to pass that on. Another question: is it better to heat fix? Cytology, I learned to heat fix, but many people say no.
I will tell you, for skin and ears, as long as you're not anticipating it being a mass. So if you're looking for yeast, bacteria, fungal stuff, I heat fix all of them. And honestly, I scorch them. I should have put this picture in, but right, limitations of time. I actually have a coffee cup warmer outside of the exam room back where my treatment area is for slides. They put the slides on the coffee warmer, and then once they're essentially scorched, then they stain them. I I wouldn't do that for an aspirate, right? If I'm looking for mast cell tumor, fibrosarcoma, no. But they cook them, and it works out good. My stains stay better longer. Obviously, let them cool off so they're not coffee hot going into the fix. But yeah, I do heat fix.
Another reason to have coffee warmers in our clinic. All right,
That's
good to
right.
know. Now, do you think an otitis externa by malassezia secondary to allergic disease could resolve only with prednisolone or hydrolyzed diet? Or what's
You
your
you
general recommendation?
it could. The problem is over what period of time and how bad would it get potentially. So if we don't see if we start a food trial and do a diet swap in an effort to help control otitis, the problem is how quickly will that change be afforded by the diet change? Because we run our trials average out 6 8 weeks or better. It depend on whose path you follow, but on average the general rule is about 8 weeks. Well, if we don't see max improvement till then, you know, that ear might be in a worse place by then. Could you see improvement? Yeah, steroids for sure, right? If the allergic inflammation resulted in the allowing the malassezia to overgrow in the ear, then certainly you could potentially steroid that and see improvement. But the other issue is there are patients that have hypersensitivity reactions to malassezia. So are we addressing that with a steroid, or are we addressing the inflammation that's related to the otitis? I think there's probably oftentimes we get those ears clinically better with steroids alone. So
Wonderful. And we have time for two more questions. So, one of them is first of all, do you ever use proparacaine prior to examining a sore ear?
I haven't done proparacaine. I have used buffered lidocaine. I've used some um, not as much bupivacaine. Usually I've buffered a little bit of lidocaine and I'll squirt it in there. But to be completely honest, guys, if that canal is so painful that I think I'm going to cause pain or harm to that patient, if they can have it systemically, I'm going to start them on steroids somewhere between a half and 1 mg per kilo per day. And I'm going to recheck them in a week or two. And then by then, I've usually gotten the inflammation down, the swelling down, hopefully the amount of exudates decreased. I've opened the canal some, and now I can actually have a valuable evaluation of the ear. And maybe I know right then I'm going to sedate that dog potentially, get in there and clean that canal. Because oftentimes we've neglected that in the whole process. We start treating and we get into a chronic recurrent ear thing because we've never gotten the garbage off of the tympanum in the first place.
All right. Thank you. All right, thank you. And then last question. What do you do if you can't see the tympanic membrane? And your pictures were beautiful. And I will say, even as a double board certified specialist, I can't see the tympanic membrane like 90% of the time. So, what if you can't see it? What medication should we avoid or potentially use?
It's that's a really tough answer, or question, I should say. If I have concerns that that tympanum's ruptured, probably more often than not, I might would grab, and it's not labeled this way. I would probably lean more toward the batralotic, and then the other thing I might would do is if it's because of swelling, I might just go ahead and postpone treatment topically, go ahead and do systemic steroids, and then plan for sedation. Because sometimes, right, what you can't see in the awake, you can clean with saline that's less likely to do harm, and then evaluate it again. But I think for a lot of us moving forward, I mean, how many people have digital x-ray in this audience? How many people have ultrasound in this audience, or a tonopin or whatever? And we've still got the same otoscope we had 50 years ago, 100 years ago, before most of us were born. So I think that's another opportunity too, because we invest in all of these things. For God's sake, I've got a CT in my little place, and I'm like, yeah, I've got some money in scopes, but it's because I started realizing what I couldn't see. And I think that's just going to be a process that we as veterinarians make that move and start investing a little bit more, at least in, because how many of you have rigid scopes to look up a nose? You don't try to do it just with an otoscope anymore. So it's the same process. It's just a period for growth.
Amen. Love it. Absolutely. All right. And last question, I promise. Again, if you guys have any feedback, please make sure to type them in. Please make sure to fill out that survey right away and enter that scary ear contest.
And see, I'm going to say, and then request to do some longer ear talks to where we can go through cleaning
Exactly. We want
processes
you back.
and,
This is
and
amazing.
procedural processes. That's
Yes.
right.
We want you back. And I think my Spanish interpretation is okay. And you touched on this, but if the stenosis of the auditory canal is that severe, do you recommend using an anti-inflammatory topically or systemically before rechecking with an otoscope?
If that ear is on fire, I start them on steroids every time, unless it happens to be a patient where I'm like, it's the chronic pancreatitis dog where I kind of got to go, okay, or the really bad diabetic or something like that. But most times I'm gonna hit them with steroids. I may not put anything in the ear, because if that ear is angry, almost anything I do might make it more angry topically. So just like if we talked about having a topical reaction with an ear medication, what some people used to do is they would rinse it out and then start a new ear medication. Well, that ear is already angry. Anything you do could piss it off worse. So usually I stay away from anything topically until I quiet it down a little bit.
It's good to know that even though our specialties are so different, no animal should die without the benefit of steroids.
Yeah.
All right. Well, thank you so much, Dr. Canfield. We would love to have you back. That was incredible. I learned a ton because my dog has chronic otitis, and I know everybody else did, just looking at all the comments. And to all of you guys, thank you so much for taking the time to learn. A huge shout out to Merck Animal Health for making this happen. And we will see you on the next Vet Girl webinar. Thank you, everybody.
Thank you.